Hi, I'm going to present pharmacotherapy for chronic pain. This talk was originally presented by pharmacist Penny Miller for the University of British Columbia Family Practice Department, and she did this for the Pain Practice Support Program. So I'm going to try to draw from her insights in that talk. So we're hoping that you're going to draw from this talk just some basic principles around the medications that have the best evidence to date. So it's not going to be a comprehensive talk about every medication, but it is going to be highlighting the ones that are commonly used today. And then also to highlight the problems with the use of those medications in certain types of pain syndromes that have been studied, and finally any controversies that have been raised in the literature so far. In these medications, I won't be addressing the opioids because that will be addressed in another talk. Well, having said that though, the principles of using medications in pain management was drawn from the original applications in cancer pain therapy. And this is, as you know, the World Health Organization ladder for using opioids. But you can see in the far right-hand corner, they've kind of appended the adjunctive therapies that are non-opioids. So again, the principles of go low, go slow, use the medications which has the least amount of side effects, is still holds true for even the adjuvant medications that are not traditionally opioids. So what is an adjuvant medication? It really is any medication that wasn't primarily indicated for pain management, such as you see in these four groups: tricyclic antidepressants, selective serotonin reuptake inhibitors, the anticonvulsants, and some topical agents. There are other groups such as the cannabinoids and local anesthetics and other types of medications that won't be covered in this talk today, but essentially they have derived pain management properties from the observations in its regular use for its normal indication. So the following few slides are going to be focused on the anticonvulsant groups, or otherwise known as neuromodulators, especially with neuropathic pain. Before I launch into the next medications, just wanted to highlight the principles that influence how we choose those medications. So they include the type of pain, the intensity, if a patient can be compliant with the dosing schedule, if they even have access to it, because financial circumstances can limit the options. But in the literature, they use the principles of NNT, numbers needed to treat, and NNH, which is numbers needed to cause harm. So in these next few slides, I'm going to be talking about common anticonvulsants. These two here are the alpha-2 delta calcium channel blockers, gabapentin, and pregabalin. Again, we just wanted to highlight that the studies have been focused in certain types of pain syndromes. They haven't been applied to all neuropathic pain syndromes. But as we have found in our practice, practically, we have started to apply them in different types of pain syndromes that may have a neuropathic component. In particular, though, I wanted to highlight the studies data with gabapentin in the use of postherpetic neuralgia and painful diabetic neuropathy. And so you can see here the numbers needed to treat are moderate, so somewhere between 2 to 5 in most pain syndromes. It gives you confidence of its efficacy in its use. In general, gabapentin is used with an average dose of 1,200 milligrams, could range up to 3,600 milligrams in a total daily dose. And usually it's divided TID. With pregabalin, it's a brother of gabapentin, and for some of those who don't tolerate gabapentin, sometimes they can tolerate pregabalin better. Also, there's a cost factor relation to these two medications and how you choose to use them. Gabapentin, onset of pain relief is a little slower than pregabalin, so pregabalin may be one that you trial first with ones that you need to see a faster effect. But in particular, it was studied in postherpetic neuralgia, and you can see that it was more effective as compared to gabapentin. So, as you can see on the far right screen, common dosages are about 300 milligrams total daily dose, but as high as 600 milligrams divided in twice daily dosing is often used. As you can see in this slide, I'm highlighting two of the older anticonvulsants, carbamazepine and lamotrigine. In here, carbamazepine has been actually trialed in a number of neuropathic pain syndromes, in particular trigeminal neuralgia, postherpetic neuralgia, and diabetic neuropathy. In this slide, we're just highlighting the fact that a lot of the trials, especially when it was done in earlier years, they did not go beyond 4 weeks of observation period. So the actual bulk of the studies don't seem to have adequate quality to make some interpretations from there. But practically speaking, they are commonly used for a lot of the oral facial pain, neuropathic pain syndromes. In this slide, I'm just talking about more details on how to titrate up the gabapentin. So depending on renal function and liver function, but in particular renal function, you may actually want to start at a much lower dose. And those on dialysis is a totally different story altogether. You would really not need to titrate up because this is related to the dialysis period. But that's not in scope for this talk today. Most people, depending on age, would start at about 300 milligrams. A person who's older than 65 may be better tolerating this medication at the dose of 100 milligrams. And often the titration period is every 3 to 7 days, depending on how they're tolerating the side effects. Unfortunately, as the doses go up, the actual amount available goes down. So surprisingly, at the average effective dose, around 1,200 to 1,600 milligrams, less than 1/3 of the dose that they're taking in is actually available for use. In general, pain relief can be seen within the first 2 to 3 weeks after you've started the medication, and that pain relief effect is really based on the actual therapeutic dose. So if they're titrating that up very slowly, it will take longer. This slide highlights how to titrate up with pregabalin. It's the same principles, the smallest doses that are available at 25 milligrams. I often start either a 50 or 75 milligram capsule and increase that every 3 to 7 days like it is with gabapentin. And the actual pain relief period is a lot faster. So some people can in fact titrate that even faster if they're tolerating without side effects. So as you can see by this slide, there's a number of side effects associated with all the drugs, but in particular with the anticonvulsants. Most patients complain about some level of the cognitive dysfunction, such as memory problems, slowed thinking, altered speech, dry mouth, fatigue. The problematic side effects could also include this peripheral edema, which leads to weight gain, and blurred vision. These are not to be missed and need to be switched up quite quickly if those kinds of problems occur, especially in the first 2 or 3 weeks.